Hello, everyone. My name is Deontay Marquis. I am a family nurse practitioner, and today we will be presenting to you activities of daily living. Now, this is our part three of our three-part series, ADL educational session. So, if you're here with me, that means you've gone through ADL part one and part two, and we've reached the end. This is ADL part three. So, let's begin. Okay, so here you can see the name of our course is Activities of Daily Living, Part 3. And there's my name there, Deontay Marquis, family nurse practitioner presenting on behalf of my ALF Training. So here is just the course objectives from ADL Part 1 and Part 2, which we're going to review over before we get into ADL Part 3, just as a refresher to make sure all this information is sticking with you when you take it into your practice. Um, so from Part 1, we reviewed that in Part 2, so we're going to really put emphasis more so on Part 2 ADL course objectives, which are how to identify, correctly prepare patients' meals, assist them with eating, um, episodes of incontinence, how we can both manage and minimize those. And also, we're going to be identifying and different approaches to safely assist patients with activities such as transferring, positioning, and actually walking. So, more importantly, we're going to be spending the most amount of time, of course, on ADL Part 3. And these are our objectives for ADL Part 3. We're going to, at the end of this presentation, be able to identify how to correctly assist the patient with safely ambulating, both indoors and outdoors, because there are some differences that I want you guys to keep in mind when doing both of these activities. Um, Also, we're going to spend some time on identifying how to properly perform a fall recovery. Falls do happen. They unfortunately are a little more common than we all would like. And there's some serious risks involved. So I want you guys to be able to stay safe and also keep your patient safe in the event that a fall happens. So we're going to talk about fall recovery. Also, at the end of this presentation, you should be able to understand the importance of and identify how to promote social engagement among residents. And there are different methods for this, different activities, and a couple different things that go into this particular objective. So we're going to talk about that more in just a minute here. And lastly, our objective for ADL Part 3 will be to identify and understand what an IADL is and when to assist patients with performing an IADL. Because the name of this course, this Part 3 series has been ADL, but there's also a slight difference from ADLs to IADLs. So we're going to talk about that today. That's something that I learned the difference between those two later in my career, but I'm going to share that with you. Hopefully it's earlier in your career so you can be that much more of a better healthcare provider. So let's begin. So you may or may not remember this from part 1 of our ADL series. These are the 3 most common diagnosis types of patients that will be needing help, needing your help in an assisted living facility or acute care facility or whatever facility it is that you're working in. So dementia, Alzheimer's disease, and stroke. These are the most common types of diseases and that affect our patients that we're going to be seeing a significant rise in the coming decade as the elderly population in the US continues to grow exponentially as these patients will also start making their way to various types of facilities to need help to help them live and function in their everyday life as they enter into the elderly stage of their life. So, what is dementia? We've talked about this. This is a term that's used to characterize a set of symptoms that is most notable for cognitive problems, which affect memory, language, patients' ability to critically think and solve problems. And if you can imagine how this may affect them on a day-to-day, task-to-task basis throughout their day, So you'll be caring for a lot of patients with dementia. And quite similarly, Alzheimer's disease is another disease which is symptoms are characterized by a cognitive decline. Now, the difference between dementia and Alzheimer's disease is Alzheimer's disease is a progressive degenerative disease that gets worse as the body ages and the patient gets older. And Alzheimer's disease can also affect the patient's behavioral skills as well, which isn't as prevalent in dementia. So Alzheimer's disease, patients with dementia, and lastly, stroke. Now, stroke, I believe, is the second, it's one of the top three, I can't remember right now. It's one of the top three leading causes of disability of Americans. And those disabilities can range from mild to very significant. So for instance, if patient A has a stroke, the results from that stroke or the symptoms that they have are, for one, they are life lasting. So the symptoms patient A may have is they may have slurred speech because of the stroke. And the same patient may have had a stroke at the same age, at the same restaurant or home, wherever they were. But the patient B may have experienced much more significant symptoms. For instance, they may have right side paralysis where they're unable to move their right arm or right leg, or they've lost a significant amount of the musculature in that right arm and right leg on the side of the body. Now, what causes a stroke? It sounds so terrible. Well, it is a very terrible disease. So a stroke occurs when there is a shortage or interruption in blood supply to the brain, and that in turn leads to brain cell death. And whatever part of the body or function that those brain cells uh, help to control, we no longer have as much or if any control over, because once a brain cell doesn't have blood and oxygen for an amount of time, it dies. So that leads to a stroke. So now that we have refreshed about the types of patients we'll be seeing, this is another ADL. Bathing is an ADL from part one. So quick summary of some key points. So when you're preparing to assist the patient with bathing, one of the main things you want to make sure you have is all your supplies. You don't want to have to leave the patient or have any type of interruption in the process, because it may have been difficult just to get them to agree to taking a bath, as I'm sure some of you can relate. Next is the water temperature. You want to make sure and don't forget that the water temperature is comfortable for the patient. And remember, it's not what you think is comfortable, but what the patient thinks is comfortable. Some patients like to have the water hotter. Some patients like to have the water cooler. Make sure that the patient is comfortable with the water temperature, and also make sure that the environment comfortability. So that means that the environment is comfortable, that they have privacy, that it's quiet, or if they prefer music, that there's music playing, and that the temperature outside of the bathroom, outside of the bathroom where the bathtub is located, is a comfortable temperature for the patient as well. Adapting the process at your facility or the way you like to go through your workday. You may like to bathe the patients in the morning, but this specific patient may like to take a bath at night or after lunch. So instead of going through that back and forth with the patient to get them to follow the regimen at the facility, I want you to adapt the process to your patient, and remember that we are here to assist the patient with their living style so that they can enjoy their life. So just remember that and adapting the process. It's very important. Making the bath time inviting. How can we make the bath inviting for the patient? You know, what can I do? Well, candles, flameless candles, incense, air freshener, music, bubbles, anything that might entice the patient and make the overall bath time more enjoyable for the patient is making the bath more inviting. So we want to take that extra step. Also talking the patient through the bath. So if you're beginning to wash the patient's leg, you want to tell them, hey, I'm washing your leg with some soap. Moving my way down to your feet. I'm going to wash your feet next. Just talking to them to let them know so they're not startled by anything. Or if they have a comment and you said you're going to wash their feet next, maybe they'll throw in, hey, can you check my foot? I think I may have a cut there. Just to get that type of dialogue going with the patient and keep them informed. It kind of decreases that anxiety as well that some patients have about taking a bath. So another ADL from part one, ambulating, um, dressing and grooming. So ambulating a patient, we'll get to that in a minute. Dressing and grooming, so dressing the patient, some key points to remember from this presentation in ADL part one, we wanna make sure that we lay out the clothes. Now, what does this mean? Just to lay them out? No, there's a specific order that we wanna lay the clothes out on. And we wanna start with the underwear on top. So the underwear should be the last thing. So socks and underwear should be on top of shirt and pants or shorts. And all of those clothing items should be on top of a jacket if it's cold outside. Closet organization. Make sure the closet is organized as well as the room free from clutter. And this is going to make the clothing selection process with the patient as easy and smooth as possible. And also by minimizing the amount of clothing that the patient has to select from, not just throwing everything away, but if the patient has a large amount of clothing, we want to tuck some away into a drawer or a dresser or put it in another room where the patient has their things or under the bed so that when we open the closet to select clothes for the day, it's only their favorite, most comfortable outfits that they can select from. So any selection is a great selection, and that's a great start to our day. Grooming, oral care. We want to make sure that the patient gets their oral care twice a day. If they're wearing dentures, we remove the dentures and clean them twice a day. Remember in part one, I showed you a video of a lady who was struggling to give a patient oral care. The patient had dementia. He wasn't fighting, but he wasn't willing. So she used the back end of a toothbrush and slid that in between his teeth and opened his mouth a little. And while she was doing that with one hand, she was brushing his teeth with another toothbrush in the other hand. So remember that technique if you're ever having some problems with your patient. Also, we want to establish routines. The patient may have had a routine prior to coming to your facility. We want to make sure that we establish a routine here that's in line with how the patient would like their day to go, and we stick to that so the patient can get back into a routine and expect and not be surprised by anything or feel like they're missing something. So they know how their day is supposed to go. So we have an idea of how we should make their day go for them. And this is in turn will also encourage patient participation. These go hand in hand. So talk to your patient, ask them how they're feeling, what would they like to do, and if they want to participate in oral care or they're even able to, we want to make sure we stand shoulder to shoulder with our patient and demonstrate how they're properly supposed to be performing oral care. Taking medications. This is some more key points for taking medications. I believe this is from ADL part two. So what do we do if a patient resists? If a patient resists, we want to make sure that we don't go back and forth with the patient, give them a detailed explanation about why they're taking the medication, talk to them about the doctor, jog their memory a bit. And there are some things we can do to prevent the patient from resisting because they're resisting because they're confused or they're forgotten. Remember, a lot of the patients we are caring for in these facilities are suffering from a stroke or dementia or Alzheimer's disease. So there is a bit of a cognitive challenge for them, a bit of memory loss. So we want to make sure that we cater to the needs of the patient. So we want to take the time to explain things to them. We want to encourage their participation, let them hold the pill, give them one pill at a time. It's a little less threatening. If someone gives me one pill, I'm more likely to take it than if they give me 10 of my pills at once. Then I may not just be up for the challenge for that day. So I may resist a bit. Also, making sure the pill bottles are out of sight. If they give me one pill, but I see there are dozens more bottles in front of me, I may not even want to start this process. I may not want to open the floodgate. So making sure we keep those pill bottles out of sight. Preparing food and eating. Some key points from this slide. Um, let's see, the importance of a balanced diet. Why is a balanced diet important? We've heard this growing up. It's important to have a balanced diet because you want to grow strong, you want to grow smart, you want to have strong bones, you want to have the energy to get through the day. The same applies for this elderly population, even though they've already grown, they've already peaked their development, much of them. So why is it so important? Well, it's important because we want to make sure that there isn't a decline, that they don't slide backwards. And by making sure they're still getting the right amount of nutrients, we can ultimately attempt to sustain a level of cognitive ability in these patients. So what constitutes a balanced diet? Well, um, there's a limit of foods with high fat and cholesterol. We want to reduce that intake. We also want to limit high sodium, preferably use less salt. Every time a package says less salt, we want to choose that option for this patient. And definitely limit their intake of processed foods. So those are several ways we can rebalance their diet, which may, I understand, be difficult because, as you see on the right side of the screen, sometimes these patients have a poor appetite. So what do we do if we've balanced a diet, we've got this perfect meal prepared for them, but the patient doesn't want to eat? um, you may be tempted to switch back to those processed foods that they were eating. But before you do, there are several other reasons why your patient may not have a good appetite. So, one, they may not be recognizing the food that we're putting in front of them. Remember, I just told you guys the last slide, there's a cognitive decline in these patients because of the disease types that they may be experiencing. So they may not even be recognizing these foods. So we want to give them a minute. We want to put the spoon up to their lips, let them get a stronger taste, a better smell of the food, and it may jog their memory. And it may have been their favorite food and they may enjoy it and eat it with no problem. Or it may have been a food that they didn't like. And then we can move on to a different food and we can say, okay, well, this patient doesn't like this food. We won't offer this for them in the future. Also, poor fitting dentures. Eating could be painful for this patient. That may be why they're not eating as much as they once did. So we want to make sure when we're doing our oral care, especially on patients with dentures twice a day, that we check the gums, we brush the gums, we clean them, and we also look for any cuts in the gums or any areas of redness that could indicate that there's some irritation in the gums that when the patient puts the dentures on and tries to eat, could be creating some pain that we're now interpreting as a poor appetite. So, medications. That's another common reason why patients may have poor appetite. We want to make sure that we check their medications, see if there has been a change in the dosage or introduction of a new medication or stopping of one. There are several medications that can be prescribed for a patient that increase their appetite, and also there may be some that can cause nausea. That's a very common side effect. That may be decreasing their appetite. And last but not least, one of my favorite go-to methods to increase the appetite in patients who don't seem to be very interested in eating, exercising. We can walk these patients before a meal, before lunch, a short walk them after, and this will just get everything in the gut moving and hopefully open up some space, make them hungry. Their body will want more nutrients, and we'll see improvement in their appetite. Incontinence management. This is a very important one. So, incontinence management, what do we talk about in part 2? Incontinence management, some key points. We talked about not withholding fluids. This can lead to more problems than incontinence for you and your patient. It can lead to dehydration, which can lead to a UTI, which can lead to increased incontinence, and even the patient becoming agitated. So we can see how withholding fluids to potentially do good for the patient can actually make things worse. So instead of completely withholding fluids, we can just decrease the amount of fluid intake after dinner or before nighttime. Um, Also, we can learn the patient's trigger words or phrases for when they have to use the toilet. Sometimes these patients we've talked about, their symptoms are more cognitive, so they may not be able to speak appropriately, express themselves as eloquently as they once could. So they may be saying the wrong thing to let you know that they have to use the bathroom, or we can watch their body language. They may be becoming more jittery, or they may sit away from the group or away from you and stand still. We have to watch our patient, know our patient, listen to them so we can identify these cues that may be letting us know, hey, this patient has to use the bathroom. We need to offer toileting. If your patient is having problems with incontinence, you should be offering toileting every 2 to 4 hours just to make sure, just to get them in the ritual and more comfortable with going to the bathroom with you and being able to hold off until you ask them to. Just creating that kind of routine for these patients who may be forgetting to even go. And that was our next slide, reminding the patient to use the bathroom on a regular schedule. And lastly, another very big tip is making it easy to find the toilet. A lot of patients experience incontinence during the nighttime or throughout the night. Why? Because they're in a new environment. They may not know where the bathroom is. They may wake up forgetting where the bathroom is. So we want to make sure that the bathroom light is always on. We want to make sure that the bathroom door is open. And we want to make sure that the bathroom is accessible to them at nighttime. And even put a sign on the door or on the wall that's adjacent to their bed. So when they sit up at night to begin their journey to the bathroom, they can see the sign that says bathroom this way. And this can help reduce the frequency of incontinence in these patients. Um, so preventing unwanted incidents, removing items that can be confused with the toilet, such as a trash can. Make sure you use non-slip mats only because we don't want the patient to fall or have a slip and then be scared to go to the bathroom alone and fall. So they end up having incontinent episodes. And if your patient is frequently and regularly having incontinent episodes at night, then make sure we get a bedside commode during the night and sit it right next to the patient bed and show them how to properly get up, pivot, and sit on the commode. Safe transferring and positioning. So we watched in ADL Part 2, 2 videos. Hopefully you guys were paying attention and took away some great key points from those videos. But here I outline just some key takeaways from those 2 videos. So to remember, you want to always, when transferring a patient, bend at your knees. Don't overextend your back. This will create issues for you, and you won't be able to always support your patient, especially male or larger patients. Always use a gait belt as needed. If you have to think that if you have to think to yourself that this patient may be a little bit difficult to carry because of their weight or just because of the overall dependence that they may need from you, then you need to get a gait belt. There's no question about it. Interlocking your knees when transferring a patient from sitting to standing. What does this mean? So this means that if this is the patient's knees, you want yours to interlock. That way you can create a little friction, and this can reduce the amount of weight that you are exerting on your arms and on your legs, and help you assist the patient to go from a sitting to a standing position. Also, lastly, a key point, bend the patient's knees when transferring them from a lying to sitting or to standing position. So what this means is if the patient is laying down and you are preparing to get them up to take a walk, but first you have to get them sitting at the side of the bed, you want to make sure you lift their knees. Now this will help them to help you as they can dig their heel into the bed to push themselves up while you're pulling them up. So bend the knees when transferring a patient, and also bend your knees. It's all about the knees. Okay, and here we are. This is our first topic of ADL Part 3. So Ambulating. So ambulating indoors is different from ambulating outdoors. So when we are ambulating indoors, there's a simple checklist of a few things that we should be prepared for. Always, 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 you should have a gait belt. Why? Because a gait belt is going to help you with fall recovery, which is very important. It's going to help you prevent a fall because you have something attached to the patient other than their shirt, other than their clothing to pull on. And lastly, it gives the patient some support and a reminder that you're there behind them, something that they can feel. Second, blood pressure. Is the patient dizzy? Before ambulating a patient, it's very important that you know your patient. So if this patient tends to have low blood pressure or this patient tends to have high blood pressure, you want to make sure that you taking a look at their blood pressure and trended it for the day before you take them for a walk or standing them up. And you also want to just ask the patient. You can always get a lot of information directly from the horse's mouth, directly from the patient. How are you feeling? Are you ready for a walk today? Are you ready to get up? Have you been feeling dizzy? If the patient says yes, it may be a sign of orthostatic hypertension, or it may just be that they've been laying down for too long and it indeed is time for them to get up. So we've taken their blood pressure, we've gotten the gait belt. What's next? We want to get their shoes. So after we got the gait belt, blood pressure, they were feeling dizzy. We sat them up at the side of the bed. We had them take a few deep breaths. They feel fine now. Their blood pressures have been looking beautiful. So shoes, we want to make sure we have non-slip, preferably athletic shoes, or if they prefer to walk around in some sort of sandal or a slide, and we provide that for them. But preferably, if they're walking indoors or anytime I'm walking the patient, I would prefer them to wear shoes, depending on their level of mobility. If they're able to walk around fine and just need some assistance standing, then I will allow them to walk in slides. But if they need standby assistance as they walk and they're a little bit more weaker, I would prefer them to use shoes. Bathroom. It's important before you start on a walk that you ask the patient to stop at the bathroom first. Why? Because these patients don't always use the bathroom when they have to use it. Sometimes they may want to get straight to the walk. They're excited to get up and start the day. They have so many things going on, they may have forgotten. They may be waiting on family to visit, or they may have been waiting on you for their walk. They may be excited, or they may not be feeling the best, or they may have new medications, just a bunch of different things that can be going on. And they're not thinking about the bathroom until you're in the middle of the hallway and there's no bathroom around. Then what are you going to do? So make sure you offer the bathroom before you take a patient for the walk. Medications. This ties into the blood pressure because you want to see what type of medications they're on. You want to know in the event that an emergency happens and they fall, are they on a blood thinner? Should I be worried about them bleeding out because they've fallen and they have a skin tear and they're on a blood thinner, which is that situation would be very prone to the patient having a significant amount of blood. Also, medications, you want to see they taking any new medications, anything that you should know about in the case of emergency that someone else will want to know about. And lastly, we want to make sure, is the environment clear? So we always want to just look around the room, check down the hallway, check outside the patient's room. Is the environment clear? Is it prepared and ready for the patient to walk? We don't want anything tripping the patient, getting behind us as we're helping the patient, catching the patient's wheelchair, making sure all the rugs are flat, none of them are flapped up at the ends. We don't want anything to go wrong with this walk because we want our patients to enjoy the walk, to be Feel comfortable and secure walking with us, and always stay safe and prevent falls. So I'm gonna show you a video here of a couple things about just reinforcing what we just talked about as far as ambulating a patient. I'm gonna pause this music here. So you'll see opening, these are of course things you guys know already. Knock, introduce yourself, identify the patient, make sure you're in the right patient's room. Tell them what you're about to do, obtain permission, close the curtain. They may not want other people looking in, close the door. They may not want people watching them get up. Wash your hands and gather the supplies we talked about, their shoes, the gait belt. Let's see, and then gloves. Wear gloves if you must. If the patient's immunocompromised, you definitely need to wear gloves. If not, washing your hands and just being conscious of maintaining a clean environment is important. So here we'll see she's walking. She walked into the patient's room. The patient's sitting. She's introducing herself, asking the patient, do they want to walk today? Now she's going to get a pair of gloves. Shoe rules. This is what we spent some time on. If a patient's feet hit the floor, we talk about their shoes. Slipper socks are not enough. Feet must be flat on the floor. Gait belt must have 4 fingers between the belt and patient if used. So if you're going to use the gait belt, which you are, you have to use it properly, but make sure it's not too tight and uncomfortable. Make sure you give a little breathing room. A breathing room is 4 fingers width. So notice that's what she's grabbing here. And I want you to pay close attention to how she puts the gait belt around her patient. So she goes from behind, she loops it under the arms, just above the belly button, through the first loop, pulls it, keeps her fingers to give her a width, make sure it's comfortable for the patient, and then she goes in through the other loop and locks it in. It's very simple. She asked the patient to place his feet flat on the floor, and now they're ready to stand. Notice how she's got her knees were sort of interlocked there. Knees were sort of interlocked there. She reaches behind and pulls the patient up. Perfect. And now they're going for the walk. And that's how we hold on to the patient's gait belt out at all times, just to let them know that we're there. And if they sort of, just fall to the left or fall to the right, we will be the first to know because we're holding on to the gait belt and we can pull them back into alignment, standing up straight. So, now, there's a bit of a difference when ambulating outdoors. Not too much of a difference, just some small things I want you guys to note. So, if you're ambulating the patient outdoors, everything from indoors that we just talked about still applies, except you want to make sure that you're choosing a well-lit area. If there's a area outside, the sidewalk is shaded completely with trees, and it's also shade of the side of a building covering those trees. It may sometimes towards the later afternoon be a little dark out there. And we want to make sure that our patients can see where they're walking. So not only are we worried about making sure the area is well lit, bright and sunny, that the patient has any glasses or eyewear that they're supposed to have. So make sure we clean that for them. And that's a part of preparing our supplies for the outdoor walk. And make sure when you're choosing, so now that you've chosen a route that's well lit, you want to make sure that it's a route that has a bench somewhere or somewhere you guys can sit comfortably and have a rest stop. You don't want to walk the patient too far past the bench And then they tell you that they're tired and they need a place to rest, and the bench is halfway back um, because you walked past that area. So even though the patient may say they feel great and we want to walk further, you just let them know, well, we can't go this way. There's a specific route I want us to follow. And that way, every 30 steps or so, if you feel short of breath, tired, it's too hot, we have a place to sit and relax. So just let them know that you have a plan and make sure that you have a plan before you take a patient outdoors to walk. Also, you want to let other people know where you are. You want to let them know the duration of a walk that you're going to be out for, and an estimated time of return, so they can look for you. If it if it's significantly past that time mark that you told them you'd be back, or if something changes with your patient and you need assistance, you can call and say, hey, we took a walk. Do you know where I'm at? I told you where I'm at. Can you send such and such to get me? They know where I'm at. I took my patient on a walk and things aren't looking too good. The patient isn't feeling very well. I need assistance to get them back. Um, Pack water and a snack for the patient. If this is a patient who ambulates fine and has a good mobility, then we want to make sure we pack water and a snack so they can be outside for a significant amount of time, even if it gets hot, even if they get a little hungry or may want a snack, or even if they don't ask for a snack, we want to offer it to them just to make it seem more exciting for them, an adventure. They had a snack outside today. It's going to be a great part of their day that they went on a walk. So we want to make sure that we uh, elevate that joy that they get from the walk further by doing simple things like packing water and a snack, or maybe bringing a music device if you guys have one to listen to music outside and just create a great day for the patient ambulating. Also, any emergency medications. If this patient needs an emergency medication of any kind, we want to make sure that you have it with you, or you've let whoever was your designated person to tell that you're going on a walk with your patient. Make sure you let them know, hey, this patient is on such and such medication. This patient has an allergy to bee stings. So if we're stung by a bee and I call, can you please bring this medication? I already put it out, it's here. Or it's in drawer C, it's in the third drawer in their room. Please bring that with you. If I call, it means there was an emergency. Just to be prepared for anything that happens, because when you're going outdoors, it's not a controlled environment. So we don't have as much control over things as we do when we're indoors. So we want to try and be as prepared as possible and always keep our patients safe. Okay, so fall recovery. So you'll see here, I've cut the screen with this line here. So we have 1, 2, 3, 4, and 1, 2, 3, 4, 5. So first we're gonna watch this video about fall recovery, and then I'm gonna talk you guys through why I have the screen split and what these numeric points mean here. So as we'll see, this gentleman here is going to be helping our patient who is on the ground. He's fallen, unfortunately. He slipped, or maybe we walked in and saw him on the ground. We'd heard the noise in the hallway while we were walking by. What do you do? So we're going to watch this gentleman closely. So first thing he's doing here, he's kneeling down beside the patient. He's checking on the patient. Are you okay? Can you tell me what happened? Did you hit your head? Did you lose consciousness? Can you tell me what time it is, what day it is, who are you? Just making sure neurologically they're still intact and they didn't hit their head so hard when they fell that they lost consciousness. So that's what he's doing right now, is checking on the patient. Patient's telling him, oh, I know the date, I know the month, I know who I am. I just slipped, I think I'm okay. So now he's asking the patient, if you saw the patient move his body a bit, I'll scroll back so you can see. Wasn't far enough. So watch, you'll see the patient, see him wiggling his hips there. So he's asking the patient, does your lower back hurt? Does your hip hurt? or do you have pain in those areas? Because if the patient has pain in those specific areas after falling, then there's something more serious that may have been damaged when the patient fell. So instead of us attempting this fall recovery, we want to stop what we're doing and we want to leave the patient there, because by attempting the fall recovery on this patient who's telling you they're having pain in their lower back and hips specifically, by attempting that fall recovery on that patient, we could be making whatever may have been damaged by the fall even worse. So we want to completely abandon the fall recovery if the patient says that they have pain in those areas. So let's continue. So that's what he's telling us now, to make sure we assess for the hip and back pain after the fall. And now, just how when we're getting a patient out of the bed to sit up on the side of the bed, laying flat to the side of the bed, we want to raise their knees up. And like I told you guys, this will help them to gain some traction in their feet to help us. So that's what he's telling the patient. And then what he's going to do, he's going to put his arm, cross it over, and he's going to roll him to his side. Now see, okay, now the patient's laying on their side, just as if they were in the bed, except they're on the floor. So the patient's laying on their side. The patient's ready to get up. So we're going to help them by sitting them up. And notice his leg positioning here. He's not on two knees, because then he would have poor back posture. He'd be completely bent over. But here he's just getting some help from his leg there. And then he's helping the patient get up. The patient has something to grab onto. He's next to the bed. That's very important. In this specific type of fall recovery that we're demonstrating, is that the patient, there's something close for the patient to use to help them up, whether you get a wheelchair or what have you. And then the patient can get up. If the patient needs more help to get from that position to a standing position, then when they're laying on the floor, I would wrap a gait belt around them. And then if you see how this patient is doing a lot of the work here, instead we could help. So his hand would actually be looped inside of that gait belt, and we could help pull the patient up. All right, so the patient's up. That was perfect. Have the patient sit back down, and then now you can assess them, talk to them, and see what happened. Perfect. So that is what the first set of 1 through 4 here is: assess the consciousness and pain first. That's the first thing he did in the video. And then next, we always want to make sure we talk the patient through the process of what's going on, what we're about to do, and to open up that dialogue box so they can tell us, this doesn't feel right, this doesn't feel right. And then you turn the patient on their side, and then you help assist the patient to their feet. So this specific method of fall recovery is used when there's something close by, and the patient is not experiencing any pain in the back or the hip or any loss of consciousness. So now we're going to watch the rest of the video, and they're going to demonstrate what to do if you're alone and there isn't anything close by to help for the patient to use to help lift themselves up. Whoops, sorry guys. Okay, here we go. So the patient fell. When you look at that, he fell. Okay. So what he's doing now, he's assessing the patient's consciousness. Can you tell me who you are? How do you feel? What happened? What's today's date? He's explaining the process. He's telling him, I want you to cross your arms over your chest. And he's putting his hands underneath his shoulder blades to lift the patient up to a sitting position. Okay. And now see, this would be a perfect time, in my opinion, to use a gait belt, just to have something to stabilize the patient. But he doesn't have one here. He didn't bring it. This patient doesn't normally fall. So what he's doing here is he's going to use the patient's arms as something for him to get a hold to, and see how he's locked his hands inside actually, to help raise the patient up, because this bed isn't here. This patient has fallen outside in the grass or in the hallway where there aren't any rails. So this is the fall recovery method to use when there isn't anything nearby for the patient to reach and hold on to, and you need to help them get up. And there isn't anyone around. So just like that, he was able to pull the patient up. Now, this method isn't something everyone can do. Like we talked about before, using a gait belt, you need to assess the patient. You need to assess the patient, determine how much assistance they will need, and if you're capable physically of providing that assistance, because we don't want to overexert ourselves, and we don't want to hurt ourselves, and we also don't want to hurt the patient by attempting a fall recovery and it failing because we can't sustain the amount of weight and assistance that the patient needs. So those are the two different types of fall recovery. So the second type we just saw, of course, you assess the consciousness and pain of the patient. If they have hip or back pain, we we uh, we forego the fall recovery. We don't continue. But if they don't, we cross their arms across their chest, and we use that as a lever to help the patient sit up, and then we assist the patient to their feet. My advice would be to implement the use of a gait belt in both of those scenarios, to give you a little more leverage to be able to lift the patient up. If you can find a wheelchair for something the patient to grab on, by all means, bring the wheelchair into this scenario, lock the wheels, and that's something similar to the bed that's stationary now that the patient can use to help themselves. So now we're moving on to recreational activities. This is a fun portion of the day for the patient. They've fallen, they had a rough day, now they just want to relax, and you want to do something to take their mind off of their fall. Um, so we offer recreational activities for the patient. Now, why is recreational activity important for the patient? They're adults. They can play games and entertain themselves. You may think that's not our job. Our job is to take care of the patient. Well, this is taking care of the patient wholly, mind, body, spirit. So we're taking care of the body. Now we need to take care of their mind and their spirit. So how can we do that? Through recreational activities. Um, Recreational activities for these elderly patients can help promote physical well-being, emotional health. They can sustain the patient's cognitive ability, and also can prove to be therapeutic for our patient who just fell, a sort of therapy for the patient. So physical well-being, patients with dementia, uh, like I said, we remember that Alzheimer's disease is a degenerative disease of the brain. So it can sustain. Studies have shown that certain types of activity in facilities such as assisted living facilities or long-term care facilities can actually stop the degeneration, of these patients' brain cells, and even in some improve cognitive ability and emotional health. We can just imagine how the same way we enjoy interacting with our friends and going out, it makes us feel good. The same way children love to play with mommy and daddy or their brother and sisters. The same applies for these patients. They're elderly, but they still have a human spirit, and we need to nourish that human spirit and care for it. And that will help improve their emotional health through these recreational activities and interacting with us and other patients. So how do we choose what activity for the patient? Um, this can be done through, of course, getting to know your patient. But if you don't know this particular patient, they're new, or you haven't worked with this patient, then just try and figure out what's bothering them. Just ask them, what's bothering you? If they're feeling a lack of independence because they tell you they're complaining about the bath time, well, then you know that they're feeling a lack of independence. So you need to do something that gives them that independence. So I would suggest scrapbooking. Tell them to make a scrapbook and give them some pictures, either for the facility, pictures of the facility, or just random pictures of outdoors, and give them a task to do by themselves, something that they can complete, and that'll hopefully restore their independence. If they're feeling stressed out, they're frustrated about a new medication or the doctor changing their medications, give them something more relaxing like music or art or painting. If they need cognitive stimulation, if they've been needing more assistance with their ADLs, give them a cognitive stimulating activity such as a puzzle or a game, something to make them think a little bit more challenging. And if they're in the need for a mood booster, as I like to call it, something like art or painting or music, those types of activities tend to increase a person's mood. So that's kind of how I would suggest to you to match up or determine what type of activity may best be suited for your patient. And these are two excerpts that I got from an article online. I want to read them with you. The first says, engagement, social activity, reading, problem solving, and creativity can at the very least improve the life conditions of Alzheimer's and dementia patients. Wow. So that's proof right there that selecting these specific activities for our patients and encouraging their participation in them can improve the conditions that have been affected negatively by the Alzheimer's disease and dementia. Some studies show that there may even be a possibility of improvement. So at the very least, we can stop the degradation and the decline of their ability to do things for themselves that has been taken away by these diseases. And at the best, we can even expect an improvement, a turn in the other direction. Now, in this second excerpt here, I turned the text to red to draw your attention to consistency over time need not be excessively structured, and there must be emphasis on cognitive abilities sorry, that involve some measure of recall and memory. So puzzles, that's why they're such a good game for these patients to play, or card games like Go Fish, or just asking them questions, giving them numbers, playing games. Be creative. But something that draws upon their recall and memory, and you do it consistently over time. You don't need to have structured games and everything so timed and the rules laid out. We just need to do it consistently over time, and slowly we will notice this. Maybe not an improvement, but things certainly won't get worse from here on for these patients. Last but not least, I know you're looking at these letters. No, it's not a typo. This is IADL. Now, what is IADL? IADL stands for Instrumental Activities of Assisted Daily Living. These are separate activities from ADLs. Now, I hope I'm not confusing you. I just want to introduce you guys to all of this information. So IADLs are activities which are related to independent living, which are valuable for evaluating persons with early stage diseases, both to assess the level of the disease and determine the person's ability to care for him or herself. More simply, IADL is an example would be shopping, cooking, doing laundry, housework. Whereas an ADL would be bathing, eating, things like that. And a clinical pearl here. So, IADL, here's a clinical pearl. Um, just follow with me. I have the clock here. You'll understand why. Uh, a decline in an IADL performance is often the first sign that an older adult may be experiencing mild or early cognitive impairment, whereas a decline in the ability to complete basic ADLs may not be noticeable until later stages of dementia or physical disability. So it's really important for you to tune in on a patient's IADL and understand what they are, because this actually is the most early indicator that something may be going wrong uh, in our patients. Um, when and how to assist. Recognizing a person's limitation is the first step to develop a care plan. So you just have to get to know your patient, determine the ADL that they need assistance with or the IADL, and make a care plan. Talk with them, encourage their participation, encourage their input. This is how we know to assist. This is when and how much assistance we know to give. Oops. Sorry, guys. So, more specifically, because I know some people like to be very specific, some healthcare providers do use three different types of tools, and these are the tools here um, that can help you identify what disability the patient is experiencing and how much assistance they're needed. So, the most popular one, the only one on this list that I've worked with, is the CATS Index of Independence. So the CATS Index of Independence, I'm going to show that to you here. It's just this chart here, and it's in three columns: activities, independence, dependence, and it has the different activities: bathing, dressing, toileting, and we put points next to them for how much independence or dependence the patient has. Total it up, and we can have a numeric score, something physical that we can see and measure how much how much assistance a specific patient may or may not need. Okay, now that's it. So that's it. That's part three. So you've completed part one, part two, and part three. All right. So we just have two more questions here, and I'm hoping that you get them right. So that way we can know that my education was the best and you did take away all of the information that you have to use into your practice to become a better caregiver with assisting these patients every day to complete ADLs and IADLs safely and effectively. Okay, so first question. You're walking your patient outside and they fall to the ground with no one else around you. You should attempt to perform a fall recovery unless the patient says, A, I'm scared I might fall again. B, I feel fine, just a little shaken up. C, my hip and back hurt a bit. Or D, I scraped my knee and it's bleeding. So which one? Give you guys a minute. All right, this was an easy one. You guys should know this. My hip and back hurt a bit. I stressed this over and over because I knew this was a question at the end and I wanted you to get it right. If the patient says their hip and back are hurting, we want to stop the fall recovery and we want to go and get someone for help, because anything we do at this point may potentially worsen any damage that was already caused by the initial fall. And lastly, question two, which of the following is not an example of an ADL activity? A, walking. B, calling the family. C, eating. D, bathing. Or E, cooking breakfast. Give you guys a minute. That's right. B and D. Calling family and cooking breakfast are not examples of ADL. These are IADL activities. And remember, patients who we see a decline in completing IADLs, that serves as an early indication that something's wrong. They may be progressing to a later stage of dementia, or it may be a signal of early onset dementia or Alzheimer's disease. So our lesson summary: identify how to correctly assist a patient with safely ambulating indoors and outdoors. We remembered shoes. We're going to remember a gait belt, check for medications, blood pressure, and we're going to plan out the route to make sure that there's enough stops for our patient in case they get short-winded or just want to take a break. Identify how to properly perform a fall recovery of a patient from the floor. So we talked about bending our knees and the patient knees, using a gait belt, and also making sure that if there is something around for the patient to lift up on, that we put them in a position to be able to grab onto it, whether it's a wheelchair, we bring it to them, just something so they can assist us to get them to a standing position, only if they're not complaining of hip pain or back pain. Third, understand the importance of and how to identify and promote social engagement. So we talked about how important it is for these patients. I read you guys that excerpt from an article that I found that tells you that memory and recall activities and games can actually stop the degradation of the brain and keep these patients functioning at the level that we're taking care of them at, and prevent them from getting worse, and even improve their abilities. So we know it's very important. So we want to make sure we talk to our patients and identify what's wrong, and then select the most appropriate activity for them to participate in. And last, identify and understand what an IADL is, when to assist with them, and using the 4 principles. Now, I took the 4 principles out of this presentation, but we're still going to talk about understanding an IADL. So we know that an IADL is different from an ADL, such as an IADL would be shopping or calling family. There are more of those non-essential tasks, daily life tasks, but still very important. Whereas ADL is essential, like bathing and eating. So that's the main difference. Now, I want to thank you guys for your participation, for following along with me for ADL Part 1, 2, and 3. And again, my name is Deontay J. Marquis. I'm a family nurse practitioner presenting to you on behalf of my ALF Training. Thank you, guys.